Officially introduce you, although you're no stranger to the audience. This is epidemiologist Fred Brown, who has been with us some 13 months. Unfortunately, this will be his last podcast for a while. I know the inside information I'm not allowed to share, but he's going to be working with an agency that wants him not to share that information until it's officially released, I guess would be a good way to say it, right, Fred?
Yes, that's a good way. I think that's a good way to talk about it.
Well, what we're going to talk about today, or at least start off talking about today, who knows where the conversation's going to go?
Yeah, well, you know what? There was so as you know, they went through a pretty significant discussion about Pfizer and putting it on making it officially okay to start injecting 12 to 15-year-olds. They were approved for 16 to 18-year-olds. And I thought if it's helpful, I can share a little bit of that data they presented to ACIP. They didn't go through the usual FDA approval process because they're already EUA approved. They have to go through an ACIP process, and there they presented some significant data. I thought I'd be able to talk a little about that. And we can talk about one of the things I tried to do was to put together that lottery system in several countries, as well as a state south of here, and I thought we could talk a little bit about incentive systems.
Oh, and then finally, masks. There's big confusion right now on the mask mandate.
Oh boy, is there ever! Yeah,
no,
people yelling at each other in Costco. So
yes, you should have a mask on. No, I shouldn't, and so we'll save that for last.
Okay, yes, with masks. So yeah, it depends on your vaccination status officially, which is hard to tell. But we will. I've got.
I did hear one person describe it as the problem is we're relying on an honor system with people who have demonstrated they have little honor. So,
I know that. Well, I think that's going to be a challenge. I'm currently disabled. So it's share my screen, but I have a.
Oh, yes, sorry. Yes,
that's okay.
We don't want you to be disabled here. That would be Matt. So.
Okay.
Hang on. As you can tell, I don't have engineering credentials here, so. Should work now.
Let's take a look. Oh, beautiful.
Oh, good. My picture is about to get smaller.
There we are.
Okay.
So I've got the conclusion up, but I better start with the starting point. So at any rate, here we are, the 17th, not the 15th. I was going to say,
make that full screen if you could, Fred, please.
Absolutely. I'm sorry about that. Good idea. So
yeah, bear in mind, Matt and I are older, and our R's aren't quite as good as they once were. So.
And Bob, also for the people who are watching on a phone. So
yes.
Oh, that's right. So this is our situation. What's happened, and people say, "Gosh, the kids are they that important?" And the answer is, yeah, they're getting more important because more and more people
I see that. Wow,
are getting vaccinated as adults, and so we're seeing more and more on a proportional basis being kids between 12 and 17 and under 12. So you can see now almost 20% of the cases we have right now, and we're still at 35,000 cases a day, 1,700 cases in Michigan on Saturday. We're actually by the worst state right now. I'll show you that in a second. So the answer is this actually does matter quite a bit for the vaccination of kids, and this is what they presented now to ACIP in order to get reimbursement for kids to get vaccinated and to confirm the FDA approval so that we can actually push this into the distribution system, which we're now starting to do as of Friday. So adolescents 12 to 17 are at risk. Right? Over 1.5 million cases have reported, 13,000 were hospitalized. So it's not that kids are immune from this, and it's actually more than were hospitalized for H1N1 pandemic, which actually does really infect young kids and kill them. And so this is a problem, and it also, of course, indirectly impacts other cells because it retains they're frequently asymptomatic. They interact with the elderly, and there are all sorts of interesting sort of models of this, of how many interactions the elderly have to have in order to catch things from kids and so on. And it turns out not too many if you're predisposed and vulnerable. So and of course that keeps the virus very active in the system and causes a lot of opportunity for the virus to mutate and continue transmitting. So here's what we did. What we did is we went through a full FDA approval takes, about 6 months. And so you need to have 6 months of safety data in order to get a full FDA approval. And we're almost there. If you think about it, we launched this on December, as I recall, around December 20th. In the United States with Pfizer. So 6 months is June 20th. So we should be able to get full FDA approval, which will then allow the military, for example, to mandate a fully licensed vaccine. But in the interim, we have this emergency use authorization. And what was interesting is that because it's already emergency authorized, we didn't have to go through another FDA approval, but we did have to go through a CDC extension approval. So we had an emergency use authorization extension into this new population. So that's what we did, which was sort of a little bit different approval process, one we're not very familiar with in the United States. So that's what we did. And you can see the kind of process. You go through the clinical trials, then you go to VRBPAC. That's the Vaccine-Related Biological Product Advisory Committee. Then you go to the FDA. That happened two weeks ago. Then you got to go to the ACIP, and this is the material from the ACIP discussion. That then the CDC gets to say yes, we give our blessings to, and then it goes to the public. So that's that process we went through, and you can see the the authorization is where we have that where the arrow is, and that's what we were doing. What this data came from This was presented last Wednesday. So what we did was a bridging study for the 12 to 15-year-olds. And that means what we did is we tried to take patients that were in the old study from 15 to 26. And then we looked at patients in the new study from 12 to 15 and said, you see, these patients are bridged. And so we can use the same data that we used before and these new patient populations. So we'll see how we did that. And you can see that basically the vaccination period, 7 days, and this is the exact same protocol we used each time. So we can bridge the study. So we had first we had 21 days apart from the vaccination. After on day 1, they were tested. After 7 days, they were tested. And then 7 days afterwards. So we have a baseline, and then 7 days after the first and 7 days after the second. And then we looked at two things, as you know, safety and efficacy. So reactogenicity is part of the safety study. Did you get fatigue? Did you have pain in the injection site? And you'll see a lot of those kind of reactogenicity piece, which indicates that the drug's working, the vaccine's working. Then we look at non-serious adverse events for all participants, and of course, we're very interested in serious adverse events. And of course, one of those serious adverse events would be death, especially if it's at all affiliated with the vaccine. So far, people have died after receiving a vaccine, but nothing's been affiliated with the vaccine or directly attributed to the vaccine, with the exception of 2 or 3 about 15 possible affiliations with the Johnson & Johnson vaccination. And you can get a sense of the way we did the study. We had it all done in e-diary, so that every day people were typing in how they felt, what the temperature was, things like that. And then we had a random set of 16 to 25-year-olds to do the bridge to the old study. And then we looked at and then anyone who already had COVID was excluded, just like they did for the first trial. So you could actually look at this trial and say it's really an extension of this other trial we did before. Here was what we did. Here is, you can see, we had a placebo group and we had an active group, just like we did before. And these were in the 12 to 15 and the 16 to 25-year-olds. And you can see we didn't stop to try to balance all of the different ethnicity questions and racial questions and location questions. Instead, they just did this as quickly as possible because it was under an emergency. And you can see that we had, in the original group, in the placebo group, you can see we had a much higher penetration of 16 to 25-year-olds who are Black or African American. Because this is a bridging study, we had enough people in the study to say, in this study, we had enough Black representation, enough Indian representation, American Indian representation, and multiracial representation to be bridged to the larger study, which did contain a much stronger proportion of ethnicity mix. So that's what we did here. So you can see pretty good representation, happened pretty quickly, pretty large number of, I mean, this is, 1,300 people being tested. I'm sorry, 1,100 people being tested. That's a lot of, that's typically about as big as our normal tests are for major drugs. So this is a pretty large study happening very rapidly just for this age group. Because we want to really make sure it's safe for this age group. They're obviously young, healthy, and don't have as bad response or prognosis if they were to get this disease as the elderly. So we really want to make sure it's super safe. And the answer is that people did have a little bit more headache and fatigue than normal, about twice as. In the overall percentage increases were slightly larger than this chart shows in the final analysis, but you do expect, as adults do, to have about the same, about some fatigue, some headaches, and some chills that were more than normal, and muscle pain that was more than you'd normally expect after just getting an injection of saline. And this was in parallel to what we saw with the people who are over 25 in the major tests. I don't know if you remember those data, but they were quite similar to the data you saw here in terms of the different kinds of reactogenicity.
Easy for you to say.
Say that fast 3 times now.
The reactions to the vaccine itself, not to necessarily having any adverse event. Here were the adverse events, and you can see that the percentages were less than, they were frequently about, less than 1 in 1,000, around 1 in 1,000. Any event. Now this is all reported adverse events. They didn't necessarily have to be associated with the vaccine. So we think, again, when you get 1 in 1,000 or so, that's a very safe drug given where we are, and a bridge to what we're seeing in the other study about adverse events that happened in correlation, not necessarily as a result of the vaccine.
Yeah, wow.
So not bad. So we had no deaths at all, and here was the percent serious adverse event, 0.4 they came up with. So very, very, very low chances of having it versus 0.2 in the placebo. So about twice as many in the placebo in the regular as in the placebo, and you can see that here their definition and included everybody who received at least 1 dose. So you could have 1 dose, have a serious adverse event. So you could actually catch COVID, which would be a serious adverse event and then be reported in. So that indicates basically this is an extremely safe vaccine again. And it's extremely safe for people of this age group across all the United States and across all the racial and ethnicity factors that you want to consider in a safety report. So this is this is very we had 5 overall events in 1,100 patients. That's pretty darn good. And then the next question we had was, well, is it working? So it's safe, but the question is it working? And interestingly, we actually had slightly better results. You can see that the kids between 12 and 15 actually day 1, and this is, if you look at the day 1, they had, they basically had a neutralizing threshold of 11.2. So they had neutralizing antibodies at 11.2 titer, and that jumped after day 52, that's 2 doses and waiting 7 more days, to 1,283. So, a 1,000-fold increase. Usually what happens and what we saw here and what we saw in the adult population was it went from about 10 to about 100 on the first vaccine to about 1,000 on the second vaccine. So it's a similar kind of jumping you're seeing from first to second vaccine. And you can see that again in the 16 to 25-year-olds, slightly because their immune system is a little bit older. 16 to 25-year-olds had a slightly smaller immune response, about half. But they also went from 7 to 10, from 10 to 100 to about 1,000 overall. And against the placebos showed no what you'd expect. They weren't injected. They were injected with salt water. They had no neutralizing antibody increases for the virus. And here is what the results was. You can see that basically nobody got sick after dose 2 in the group that was vaccinated, and 18 got sick during the time of the study. So you had 18 total. You let everyone who was injected go out into the world. They were exposed to virus, and then you evaluated whether they got the vaccine, whether they got the placebo. And 18 of the people, of those, all 18 were in the placebo group. None of the 18 who got sick with COVID were actually injected with the real vaccine. And those who did get injected with the real vaccine, 0 got the disease. So 100% effectiveness, and very, very safe vaccine. There were no severe cases, and there were no deaths. So that's great news, right? Now, go ahead.
I just said, indeed, that's great news.
It is really important. I'll show you some of the reasons why. Now they represent almost 22%. About 20% of the total population of kids under the age of 20. In this age group, they're about 10% of the population in this age group has COVID, and we're having trouble, getting that number down. That 35 numbers, flattening out. 35,000 number is flattening out because we have this increase now in the kids getting sick. So the adolescents. Now here is what the results were, though, of adolescents and parents. You can see that 51% were saying of kids saying, yeah, I'm willing to get this drug, but 20% said probably not, or definitely not. Almost 30% of people said no, and that's similar to parents who also were pretty hesitant to getting this drug, despite these great outcomes. And I think we haven't really talked about how great these outcomes are and how safe this vaccine is and how important it is for this group to get vaccinated. And of course, the hurdle's higher because, as I said, these kids don't get as bad. They don't have the same death rate by a factor of 3 or 4 versus people over 60 when they get COVID. So there's less of an incentive for them to take the vaccine. You can see that basically the males were less hesitant, and that basically those of more educated parents also were less hesitant. Interestingly, there's a similar kind of effect of the Midwest and South being more hesitant in population versus the West and Northeast coasts that we see in parents. So not surprisingly, parents influence their kids and their feelings about vaccinations. So interestingly, there's no differences by respondents by race or ethnicity, though. And we're seeing that more and more. We're seeing that there's in adult populations also that initially we had more hesitancy among the Black population, Hispanic population, and now there's a slightly lower, just within 2 percentage points or so now of the white of Black hesitancy being just slightly more than the white hesitancy. Hispanics actually are more seeking the vaccine, but have more trouble actually getting the vaccine. We're having a lot of trouble with access in the Hispanic populations, which is troubling because they really want the vaccine. They're seeing huge death rates. In fact, it's so bad that their overall life expectancy in that population, Hispanic population, is lowered by almost 4 years of COVID. So that's a real important group to get to, and we're having trouble doing it. You can see here's the overall, what if you go to your doctor, what doctors are saying, and you can see that in the 85%, 83%, 77% range. Pediatricians, of course, those patients aren't affected yet. We haven't gotten the data yet, so they're going to be a little bit more hesitant. If you go to your pediatrician or the 12-year-old, for example, they may be a little. They're not as familiar with the COVID shot as the family physician or the general medicine physicians. So you might get a little bit more hesitancy because they're just less aware because of the nature of the fact they're dealing with younger kids for whom this hasn't been approved yet. But generally, physicians are extremely positive about this. 97% are willing or somewhat willing to give the vaccination. So that's these are scientists, clinician scientists who have made an evaluation and think everything is looking good, which I think is appropriate. And that was back in October that survey was done. So since then, I think I would be surprised if I saw any physicians that really hesitant at this point. Here's what we're going to do in order to increase the access for adolescents. We're going to start to use the existing infrastructure for vaccination. This includes all your hospital sites. Then we're going to add providers that can reach adolescents. Those are the pharmacies that are, and some of the venues that adolescents reach. And then we'll have school-focused strategies as well. We'll probably partner. Right now, there are a lot of states that are putting out bids to ask, can you, vaccinate or can you test all of our kids in this school district or in this county or in this state? And there have been a lot of RFPs going out from states at this point for providers to do this, and I'm sure we're going to have plenty of access by midsummer before the school starts for high school students. I don't think will be completely approved for the younger populations, especially those under 6 months until next year. But at least most students could be vaccinated, I think, by middle of September in the upper grades, and by a little bit beyond that for the lower grades. So overall, for this particular result, you can see the 12 to 15-year-old Pfizer test, 100% efficacious. Serious adverse events was very low, and none of the serious adverse events were judged to be related to the vaccination. So we have to report anything that happens. If you turn purple, 10 days after you've taken the vaccine, you could have swallowed a balloon, but it could have been a result of the balloon, so we report it. Not one, though, of the serious adverse events was found to be at all related. They were reported, but not related at all to the vaccination. They were, and you can get a sense of all these areas. So the benefits was very high. Well, it was high. That's the type 1 is the highest you can go, and certainty for critical harms. That's the risk that if you don't take the vaccine, if you do take the vaccine, whether you would be harmed is considered very low. So the benefit that what we do ultimately we say, here's the risk, here's the benefit. Risk was extremely low. Benefit was extremely high, so this is really a no-brainer for the group, and it was really a nod to the scientific community that, wow, great job. And I think we'll see the same thing when we get the results of the pediatric test as well. We're going to continue to do this is VE's vaccine effectiveness. That will continue. Those will be continued based on both the FDA and the CDC recommendations. They're going to do it they want to know how long the duration of protection is, what the genetic variation is. Will we support and be continue to defend against variants? And younger and younger children will be involved in the assessment. And you can see they want to look at test negative case control. So they want to look among healthcare personnel. That was finally reported, and they found that case negative rates of vaccinated healthcare workers versus unvaccinated workers, 90 in Israel, they did the test, 97% and 84%. And for the United States, in 33 states with a large number of healthcare personnel, I forgot the exact number, but a large number of healthcare personnel, 94% overall effectiveness in the real world, and 86% for avoiding symptomatic, and 84% for avoiding asymptomatic. So we've done that, and that test negative design was the reason that the CDC those figures were released on Friday, and that was the reason that the CDC on Thursday said it's okay to start removing your masks because of this because of the result of this test that was reported by the CDC. And then they also, though, want to continue testing in these other areas to make sure that the outpatients don't have issues, to make sure that the American Indian Native populations get a better representation. They want to make sure that adults and children also have the same asymptomatic rates. They're not transmitting. This is looking at whether you're transmitting the virus further beyond, even though they've been vaccinated, or whether you're getting breakthrough outbreak in people who've been vaccinated. And we're starting to see a little bit of those breakthroughs coming through at a very low rate. I'll show that in a second. So that's all of the continued assessments we're doing with the vaccines. And what we also found is that it's fine to co-administer. So if you're thinking about eventually making this a childhood vaccine for coronavirus more generally, you could imagine getting this as part of your series of shots, and you don't have to worry about the timing of that vaccine versus other shots, or whether you've been administered other shots. There's been no cross reactivity. We've injected this so many times and so many people, we see cross reactivity between vaccines. By this point, we don't see any. So that's great news. We can move toward what they call polyvalent vaccines, which I'll show you in a second, and of course, doing more inoculations earlier in people's lives. So here's the equity, and as I point out, the Hispanic Latino numbers were the worst for us, and that's because they don't have access. The Black non-Hispanic is also underrepresented overall as far as who's actually gotten the vaccine, and you can see the white non-Hispanic is ahead of schedule. So we're having some problems generally with our delivery systems. It's not just a matter of hesitancy. As I said, basically the Hispanic Latino are actually seeking the vaccines more heavily now than the whites populations are. The Black non-Hispanic is about the same level of seeking the vaccine and non-hesitancy as white, but they're still underrepresented in the overall injection rate, which is a problem we have just with the equity system in our health system, unfortunately.
Fred, do you think this vaccine might eventually be of the type of thing you get as a baby? At 6 months, that kind of thing, 4 months, 6 months, because you get your first shots, I think, at 2 months now.
That's right. And the answer is we are hoping so, and I'll show you why at the end of the presentation. It'll be more effective to give it as a childhood vaccine, especially for coronaviruses overall. Not just for COVID, but for all coronaviruses. And that's what we're working on. The Army is probably... Oh my gosh,
meaning the common cold. Holy cow.
Yeah, exactly. Exactly. So we're getting there. Yeah. Now, so the answer to the question is absolutely. This should become a successful childhood vaccination, and it will protect the children as well as the elderly. And I'll show you just the benefit of that in a second. The investigating breakthrough cases, you can see that there are some breakthrough cases. 95 million, now it's 115 million, but at the time that this data was gathered as of 4/26/21, 95 million, we still have slightly under 10,000 breakthrough infections. So you can get a sense of the breakthrough infection rate. Now this includes people who haven't been going through this includes everybody who's been injected, and after 14 days of the primary series. So there'll be the 2 vaccines plus 7 days, or the 2 vaccines plus 14 days for Moderna, 2 plus 7 for Pfizer, and then 1 plus 7 for J&J. And so we have had actually 232 people have died have died after getting the vaccine they had COVID, but that necessarily wasn't the reason they died. There may have been other reasons they died. So that sort of gives you a sense of over 100 million people vaccinated, and of that 200 people or so.
That's like 0.01%, I think, something like that, if my math is right, of the breakthrough cases, or 0.1%.
Better. Yeah. Well, if it was 100 for 1 million, that would be 0.001, wouldn't it?
Okay. Yeah, that is. Yep. Okay.
Something in that order. Yeah. So
reporters in math, not so much usually. So
those decimal points. The point is that you are, and that's the reason that we're starting to say it's okay if you want to start removing your mask and if you've been vaccinated, because your chances of coming through with this are with a deadly disease,
that's pretty amazing.
Extremely low. The problem is that people who haven't been vaccinated are completely unprotected. Mike and I last week went through all of the drugs that have been developed and are in pipeline right now for COVID disease, and it
took them all. Yep. So
yeah. So what we're doing now
is bourbon one of them? I was hoping.
I was reading during the Spanish flu pandemic, they prescribed whiskey as a way to eliminate the bug that was going around.
Okay, all right.
Not recommended. It also causes you to become much more social sometimes.
Yes.
Yes. Yeah. You think you're much more interesting than you are. That's right.
Oh my gosh, you start to lower your guard with that stuff. So not recommended today, but back in the day, I can understand why it could cool some nerves. But here's so we are trying to create booster studies against the B1.351. That's the South African variant.
Oh boy, yeah.
And Pfizer have these now in phase 2 development, so they're getting there. Phase 2 results of the 351 for this is for Moderna. The M1273.351 is for Moderna. You can see those results. You can see that sadly we didn't have we had very low neutralizing antibody levels, but they still think that the titers they had were protective. They were both easy to be boosted, so the boosting won't cause safety issues, and it won't reduce your efficacy. And the booster was indeed more effective at neutralizing the 1351 variant than the original vaccine. So now what they're doing is they're actually going to mix these two, so they'll have they call a bivalent vaccine. Each of the little particles will have a little piece of both of the antigen from the spike protein of the original and the new South African variant. So you don't have to get 2 vaccinations, you just have to get 1. And now they're also thinking about combining with the flu as well, so you only have 1 vaccine each year for the flu and for the variants that are coming through. That's the plan right now. We think we can go from, if we really get the system down well, like we have for the flu, we can do that in about 3 months. We can go from a variant detected to be the one that we want to target to a 3-month approved vaccine if the regulators are aligned. If they make you go through a slightly higher threshold, then it'll take 6 months. But we're still in a single season going to be able, I think, to create vaccines that are going to be able to start to fight the variants as they arise. Here are the variants of interest that you've got. You can see these are variants of interest, and so we got 1526 and the 1526-1, and here are all the different binding domain mutations that you want to look for. And the B1526 is a problem because it has the EEK. It does have the EEK 484 mutation, which reduces the efficacy of the antibody and reduces the neutralization opportunity for convalescent plasma. And you can see that continues through the India issues that we're having at the binding site as well, where a number of Indian mutations have arisen that are also quite hard to fight, as well as the Brazilian one. So that's what that looks like as far as the variants of interest that we're seeing and monitoring. And then here are the variants from those. The CDC then kind of narrows it down to variants of concern. And then you have you've got I think you got the next level. The last level is variants of immediate impact. I think if you have a variant of immediate impact, you've got to get that's a big problem. The variants of concern are things we monitor. So here you can see the ones that we're monitoring in the United States, directly why we're worried about them and what's coming at us. So the P1 and the 1351 are the ones we're really worried about. The ones from California, ones from United Kingdom are less important. The reason that's important is because here is what the actual populations look like. And you can see that whole brown yellow line, the V171, which we think we don't have to worry about too much, 72%. But you can see that the pink ones, which we are really worried about, that's the New York variant, the 1526, is 7%. So it's growing a little bit. But if the V171 can fight it off, so it's virus against virus here, variant against variant, then it'll really help us because we can kill off the V117. We can't kill off the B1526 so easily. So if the 1526 starts to win that fight, we are going to have to start to respond. But if B117 becomes the prevalent virus, we can fight that one with our current vaccines. So that's where we are with the internal fight, variant to variant. And here's what the distribution looks like. You can see that the reason New York on the Upper East Coast, despite the fact they have the highest vaccination levels in the country, are still very conservative about the last CDC. They're still evaluating whether they want to follow the CDC guidelines that were just released. The reason for that is they have so much of that pink in their circles, and that's a much more dangerous variant than what they got in California, West Coast, and down the South. And so that's why you're seeing a slight difference between the health groups responding in different ways in different parts of the country. And those regions, by the way, are the FEMA regions we've got, and the CDC regions we have mapped out. So when you're responding to these different requests for proposal and so on, that's how you respond in these collections of jurisdictions. So what we're really interested in ultimately, and what we don't know, is the precise, what they call correlate of protection. So at what point, every one of these, you could see that if you're not vaccinated, you've got 10, a titer of 10. If you're vaccinated or you've had the disease, you got a titer of about 100. When you're doubly vaccinated or you got with those 2 doses, you've got a titer of about 1,000. What we're not sure, and so what this shows is you got a lot of protective margin, because you've got on that little chart you see, that is a logarithmic chart, so that you've got a lot of protection initially when you've been vaccinated. The elderly have less. The B117 virus brings it down even more because it has some mutations and it's not a perfect fit anymore. And the 484 and future escape variants might bring us just below that protective margin that we've got. So right now we have enough protective margin, but if this EEC484 and other mutations which are starting to show up in India start to come through, we may have more and more breakthrough and maybe not have the protective margin that we need, and at that point a new vaccine is needed. Otherwise, we can probably just work with boosters of the existing vaccine, and we'll probably need those in the fall. And many of the elderly population that was injected in kind of December, January of this year may need to be re-injected around Thanksgiving to protect them as people move into the home again. So you can see we don't really know what protective margin is for these vaccines, and that's something we're studying right now to figure out, and the CDC is testing for. And we also don't know how long. So that the reason we need to understand that is because we need to know whether or not it's because we don't have enough protection, enough efficacy. If that's the case, we need a new vaccine, or if there's just increased breakthrough of the old vaccine, that would mean just a booster of the existing vaccine, or whether it's because the immunity started to break down, that would again mean a booster. So if it's because the VE or the vaccine efficacy is low, has too low a correlate of protection, new vaccine needed. If it's more because we've got increased infection or because of the duration of immunities, then we just need a booster. So that's what we're trying to figure out right now. And here's where we're at and looking at those vaccines. So you can see how much has come down, and you don't want to go above that 10 line. The reason you don't want to go above that 10 line is because AstraZeneca failed to be effective in South Africa. And you can see that they were just hovering around that 10 line. So once you get close to that 10 line, if you go over it, that's the problem. So you can see that we're going to have some problems with South Africa vaccine, even with the mRNA vaccines. We're going to need a booster. That's why they're saying, there's enough over that 10 line, probably among the elderly, for the Novavax vaccine and for the mRNA vaccines, and certainly for AstraZeneca, that if the 1351 comes through, which is very similar to the one we're seeing in New York and India, that we're going to need a booster. At least, and possibly a new vaccine or a bivalent vaccine. You can see the other ones, though. The 1526 is looking fine. The 1526 plus the E variant, we're getting pretty darn close. And the 1617.1 in India is looking downright scary, right? That's getting really close to that 10 line. So that in the fold reduction. So that's where we are with all our testing right now. Now we had to do a lot more. The N is only 31 in this, so a small number of tests, but we're starting. And so you can see this is the largest impact we think is going to be South African. Next is Brazil. Next is UK. Now we think actually the Indian 1671 might be even worse. But we're monitoring all that. And we don't know that enough about the whole immune response we're having to the vaccines to really be able to identify whether it's going to be whether they're really going to be safe for a long period of time, short period of time, and exactly how safe the different people will be based on their individual risk categories, which we'll get into in a second. So you can hear some of the reasons that you have such variation, and there is a limitation in our sample size. We're just not doing enough testing, and enough vaccination post-testing.
Well, that's been your mantra since this thing started.
I know.
Insufficient testing.
Yeah, you can see, half the studies are still in preprint. They don't have enough large enough N to be significant, all that. It's very frustrating because people are in a hurry to get the right answer. And so they're pushing themselves, which is a good thing. The bad thing is people look at this and go, oh, they didn't quite do it the way we would have suggested. So here's the efficacy, basically, we think we've got. And these are where they've done the tests. And you can see that we're still pretty good uses for most of these variants. The Pfizer and the Moderna vaccines, the mRNA vaccines, are very similar, so they didn't break those out. Pfizer was considered a Moderna piece here. Janssen, Novavax, Janssen, of course, AstraZeneca are similar technologies, and Novavax is a protein subparticle technology that's coming out shortly, which may be providing us even better long term. It takes longer to produce them because they have to produce all those little protein particles and then attach them appropriately to the vector. So it takes a little bit of time, but they can be they might be a big portion of our armamentarium. As you can see, they have slightly larger numbers against except for the South Africa variant, which we're worried about most, as you know. Here's where we are in the United States, but we're about 37% fully vaccinated. So now we come to the question is, did the CDC jump the gun slightly? And
yes, the mask question, yes.
This is the mask question, right? So in other words, if you're walking around and everyone's saying, and no one's wearing a mask, chances are they're not being fully truthful about their vaccination status, right? Right now, about 1 in 3 people could go around without masks. The vast majority of those people, about 60% of those people, should be over the age of 60, right? So if you're, so you don't all you have to do is look around, and about 1 in 10 would be people below the age of 40. So that gives you a sense of whether you're seeing people being, really acting on the recommendation or not. And my sense
I think I mentioned to you, I get my nieces and nephews' Facebook feeds, and they grew up in West Michigan, so they are very conservative, and they don't plan on getting the vaccine. And they were debating on their Facebook pages of whether to say they were vaccinated so they could run around without a mask. And I was like shocked, so.
Well, unfortunately, this has become politicized. They probably don't mind wearing a mask as much as they just mind being affiliated with.
Yeah, I think that's really what it is. So,
people, not being cool, and unfortunately, it's a lot of people, right? I mean, you can tell Michigan's right in the middle. We're exactly kind of the 25th state as far as this goes. Vaccination levels go, and so if you're seeing. As I said, I told you the numbers. 9 in 10 people under the age of 40 should be wearing masks right now, especially if they're indoors. And 4 in 10 over 60 should be wearing masks indoors. And I don't see that. I saw a very marked shift, walking around in the last few days. And I think that's a disservice. I think that's that could come back to haunt us because it allows the virus to keep it at a higher level.
We'll know for sure in a month, won't we? No doubt about it.
Actually, I think we won't know for sure till Thanksgiving. I think
really?
Thanksgiving, because we have a natural in summer, we'll be outside more. The virus is subdued a lot more, and people are naturally more protected in the summer. I think we might see a breakout in the South where they have more air conditioning. People start moving inside in June, July.
That's also the least vaccinated. That's also the least vaccinated part of the country. I'm looking at the former Confederacy on this map.
Yeah. So yeah, it's a big problem, and not only that. This is we've probably got, here. So here is the projection. It'll probably be close to safe doing this when 70% or more people are vaccinated. At the current pace, you can get a sense of this projection. We think that 70% of the population will be inoculated by September 1st. At 85%, I'm feeling a lot more comfortable, but that assumes that hesitancy doesn't take over and everyone's convinced to take the vaccine, or we have mandates that force that much of the population to get to that point. And right now, I think we're going to kind of peak out at around 70% or so without a lot more push. And that's probably not going to be quite enough to get to true herd immunity. There'll be quite a bit of continued sickness and death, sadly, among unvaccinated populations because they won't be protected by the vaccinated ones. And you can see we're going down, down, down. We were up at 4.6 million doses, on April 11th, and then we're down at 1.9 now. So, dropped by half in the last month.
Okay.
So here's the protections. And this is sort of interesting. The question is, what happens when, and this is what Michael's getting at when he says, what about when, you're unvaccinated and masked versus vaccinated? And so this is a graph that kind of says, here's your level of protection. If you're vaccinated, you have a very low risk of getting the disease. If you're immunocompromised or you've got a number of complications that are going to put you at high risk, then you've got a pretty high risk of not just getting sick, but of dying. And so you can get a sense of what we've got. And what we have is when you're immunocompromised or can't take hopefully you'll take other precautions because you don't want to die. If you don't have, not vaccinated and you're indoors, all the way up through being masked, you're really being a free rider, right? You're saying, hey, there's enough people around me who are vaccinated that I don't have to take on protections because the vaccine can't find me. I'm going to hide among these people who are well vaccinated and everything's going to be cool. And so that free rider question is, how many people want to take that chance of getting sick in your population and what your mix is? And that kind of, and there's some things that come out of this kind of a graph. The first is, if the prevalence in your community remains high, then you're going to have to be, if you move from a low prevalence environment to a high prevalence environment, you're going to want to take different precautions, even if you're vaccinated, because you remember, you're only 95% protected. It's not 100% protection. So you could come down with something if you're around people, especially if you're flying to India or in big venues with lots of people who might be sick or aren't vaccinated and carrying the virus. That something could sneak through and get you. The value of vaccination levels also increase for the high risk and immunocompromised. The relative value of these vaccinations are very high, which means that what's interesting about this, that gets to your question last time, Matt, was, so shouldn't this be a childhood vaccine? And the answer is yes, it should be a childhood vaccine. And the reason is because they are the most valued players. They have the longest to live. They have the least chance of getting a bad disease. And if you then protect them, if you also protect them from getting a disease to begin with, then you're that much safer for society as a whole. So initially, you want to get the highest risk patients all protected as much as you can with the vaccine, and then you actually do want to move to the childhood vaccine, because every time you're injecting the child, you've got a very you're injecting the most resistant to begin with a great protective agent, which causes the rest of society more protected, if that makes sense.
Right. So the bottom line is, let's do the tests and give it to younger and younger. And this is not the summer for that trip to go see the Taj Mahal.
No, probably not the Taj Mahal. And here, if you do game theory, I don't know if we've got enough time. Maybe just 2 minutes. How's that?
Okay. Yeah, this looks like that old chart about believing in God and whether or not God actually exists. Is what it kind of reminds me of.
This is actually the prisoner's dilemma. What happens in capitalist and free society is you've got a prisoner's dilemma, right? And if you've got two people and they're both vaccinated, everything's wonderful, copacetic. If both people are negative, then if both people have not been vaccinated, you got a high risk of both those people getting sick. You've got one person who's vaccinated and one person who's not vaccinated interacting. There is where you've got this prisoner's dilemma. So if because then the person who's been vaccinated, done the right thing, could get sickened by the fact that the negative person, the person who hasn't taken the vaccine, has allowed the virus to continue to populate and grow variants. And so the question becomes, how do you best fight this from a policy standpoint? And you've got two options. The first is you can increase the sticks. You can say to people, naughty, naughty, shouldn't do that. And so if you look at what China does, they don't have enough vaccines for, I think they're at 1.8 billion people now, something like that. They don't have enough vaccines. They have 200 million vaccines. So what they're doing is they say, we can't vaccinate everybody, so we're going to cause this to be a real stick issue. And if you're found, not complying with the rules of masking, we're going to, you're going to be, we're going to track this carefully. We're going to watch this carefully. And if you're in violation, you're going to be, really, we'll put you in prison. We'll do all sorts of things. And so what they're doing right now is they've got the green light system. And if you come up with a red light or an amber light, you're not allowed to move. And it's really, so if you're unlucky enough to be in a building where someone who got sick was anywhere in that building, you're going to be told quarantine for 14 days to protect the rest of society. The issue is, if you want to use a stick, you got to have a lot of policing power, to be successful. And so that means all of the businesses so if we want to do the United States, say everyone must wear a mask, that means that the airlines are going to have to enforce it, the hospitals are going to have to enforce it, the businesses are going to have to enforce it. And if you're running a bar, and you've got to enforce the mask policy, you're sort of digging into your own profits. And so you've got a big boomerang effect, because if your penalties are so harsh, it's going to really cause people to disincent, and people are going to have such a large incentive to cheat that they will, and you'll have a bigger problem than you started with, if that makes sense. The other option we've got, and what we work with in Ohio, is that you could increase the carrot. You could make it make people a lot more happy about taking their vaccine. And, in Connecticut, we used free beer, and in Ohio, we used a lottery, and everyone, people who were in the vaccination list would be eligible for $1 million, and a better chance of winning than in the mega lotteries you see across the states. And what we found, we've done this in Africa with the Ebola virus, we've done this in Spain with H1N1 virus and so on. What we found is that it's better to give a big output to a small number of people. That attracts a lot more people, because people have a good sense of risk reward. If they think they have a chance of winning the $1 million, they're going to do that more than they would if you give everyone. This
is one of those instances where people being bad at math actually works for us.
Yes, and there have been two guys who've won a Nobel Prize in economics. Kahneman won one. You want to read all the mathematical theory and the behavioral theory, you can read in Kahneman's work. But basically, carrot, if you have a great protection, you want to use carrots, because you want to get everyone to use the protection. If you don't, and sticks, if you've got something that's super risky to do, and you can catch people doing it, that causes harm to the rest of society, you want to use a stick.
Yeah.
But it's hard to catch people because it's an honor system. So, and unfortunately, right now, Michigan is the worst state. We're not in a place where we're going to be able to use an honor system very effectively, because everyone's going to see the behaviors of the other states and say, we should be able to do that too. And the answer is, well, Michigan's a little bit different. We're a little bit off compared to the rest. And the United States compared to other countries isn't doing that well. So if you look at what is happening in the UK, the final question is, how many people are dying? The answer is, if you're in the UK, you've got a 10 times less chance of dying than if you're in the United States, despite the work that we're doing with vaccines. So understand, we're implementing this the best we can, but it's not as good as it should or could be. In fact, you can see these numbers. So we still have a lot to learn. We don't have the infrastructure we need to have in place to really manage what we're doing. But we're trying to do I think the CDC is under a lot of pressure. And I think they jumped the gun slightly, which we're going to pay for in the long run. My conclusion is to continue to use the precautionary principle, right? And here are some of the numbers. You can see, don't wait and see but don't take lots of risks and then wait and see if you get sick. That's trust us that it might not be as good as you think, and be protective for your level of risk. If detection systems are poor and risk remains high, then play it safe. Right now, our detection systems are miserable. We don't do nearly enough testing to understand what our true levels of risk are as a society and as a community. In Michigan is one of the better states for this, and we're not very good compared to where we need to be. And sadly, mask removal will not be sufficient carrot to drive vaccination rates. I don't see people saying the reason I'm not getting vaccinated, the reason I will get vaccinated is because I can take off my mask. That I don't hear people saying that. I don't think that's an issue. And I think as a result of that, this is going to become a larger political statement than it has been in the past, which is disappointing. And it's something, it's hard to fight, but you just have to understand that your response to this virus needs to be about your individual level of risk, not whether you're a Republican or a Democrat or an independent. So make a decision based on what your situation is, not on what your friends are doing or what your cliques are doing. My feeling is that Michael's comment about the honor system failing, it will, because people don't interact. If you interact continuously with people people at work and so on, then I think an honor system will work. But generally out in the public, where you're interacting with one person, in a parking lot or in a store that you never see again, the game theory says that the honor system won't work in that system. And we really need to go to a mandate for the children, trust but verify solutions. If we're not willing to put in a lot more money into the carrot solution like Ohio has. By the way, Ohio's doing this for free. They're just using their federal dollars in a lottery. So we could do that in Michigan as well, as far as I'm concerned, for free.
Yeah, we got $11 billion from the feds, so.
Yeah, what's a few million compared to that? That's nothing. That's chicken feed.
I think you should make it $1 billion lottery, then everybody would.
Everyone would sign up.
Make it really enough money to ruin your life.
That would do it. Yeah.
Oh my God.
So so continue to wear a mask if you're inside, especially if you're around at-risk or immunocompromised people. That's 41% of our population.
Wow.
And if you're traveling. Know your personal level of risk and have empathy for the people who might also have a personal risk level, and act accordingly. And be ready for Thanksgiving or Christmas, because even if we have a good summer, I think we're going to have some challenges. I think our benchmarks are wrong when you have to put some money into infrastructure to manage benchmarks, even if it looks like it's superfluous and not very important anymore. So those are some of the thoughts I have.
Wow. Well, and Fred, that's fascinating as usual. And once again, congratulations on the new gig. We will miss you. Stop in when you can.
I will. I'm looking forward to it. I'm hoping that we're going to be in great shape and have a good summer. I hope we will. I think we will.
Four-year students love Lawrence Technological University's thriving campus life, but LTU has always met non-traditional students' needs too. Lawrence Tech offers over 100 degree and certificate programs that can get adult students started or back on track. And most of our classes are conveniently offered evenings at our beautiful Southfield campus or online, so you can balance your social, family, and work life even while you power up your career. Lawrence Tech, where Blue Devils dare.